Good morning, everyone. It's Melissa Andrews with LeadingAge Virginia. Welcome to our weekly coronavirus member update call. I'm grateful that this morning we have, Paul, if you can move to the next slide, that we have some special guests who are going to share some really important information for us. So I'd like to first start with Shana from the Department of Health. Shana, thanks so much for being here yet again, and I'll turn it over to you.
Great, thank you, Melissa. Can you hear me okay?
Loud and clear.
Wonderful. Well, thank you for having me back again. And this time I'm going to be talking about the nursing home antigen testing recommendations that we have recently released. And I first just wanted to start off with some background. So HHS is distributing point-of-care antigen testing devices, and there are currently two out there, the Quidel Sophia and the BD Veritor Plus, to nursing homes. HHS is determining priority groups of who's getting them first across the country based on data from NHSN. We are aware that some nursing homes have either received or are about to receive some in Virginia, and we expect to hear more information in the coming weeks about who else might be receiving these machines. And then just sort of why are we talking about antigen testing right now? These machines have been authorized by the FDA for over a month now. However, we are aware of testing turnaround times, and that has definitely ebbed and flowed. It seems to be potentially improving, but we know that there are still issues. And so we have the molecular test, and then we also have these antigen tests. And so we really need to come up with a strategy to use all the tools in our toolboxes. And we need to find alternative solutions that will still accomplish those same goals that we have in long-term care facilities. And those goals are to rapidly detect cases, implement infection prevention measures, and then ensure that transmission is not occurring. And so testing is a big part of that. So you can go ahead to the next slide. And this slide is just comparing and contrasting kind of the two types of viral diagnostic tests. So like I mentioned, molecular tests have so far throughout this response been sort of our go-to gold standard. But these antigen tests are also viral diagnostic tests. And so I just wanted to point out some differences, and just so whenever we're thinking through how to interpret them and how to use them, we sort of understand the background. So molecular tests, also known as PCR tests, they detect nucleic acid from SARS-CoV-2 viral RNA, whereas antigen tests detect the presence of the SARS-CoV-2 antigen. So again, we're kind of looking at a little bit of a different target whenever we're using one of these two tests. Both of these tests have the ability to either be performed at point of care or can be run at more of a moderate or high complexity lab. But there are differences in the numbers of what kind of tests are available. So for molecular tests, there are 4 point of care molecular tests that are authorized by the FDA. The non-point of care tests, the molecular tests, there are so many. They are listed on the FDA's website if you're interested in looking at them, and every day they're kind of adding more to that list. Whenever we look at the antigen test, there's actually only 2 that are authorized by the FDA for both point of care and to be performed at sort of a more moderate or high complexity laboratory. And I just wanted to point out, the differences in test performance. And so for the point of care molecular test, I chose the Abbott ID Now. I think that's the one that's potentially being the most used, or at least the most talked about. So people might be a little bit more familiar with that. So whenever we look at the Abbott ID Now with the sensitivity and specificity, I listed the data there. I do want to give my kind of disclaimer on the test performance data that I took this from the initial manufacturer's insert whenever they initially published and released that they were authorized for use. There are differing data out there, depending on where you look, what study was done on the sensitivity and specificity of both the Abbott ID Now and the Sophia and BD. So I just kind of wanted to point that out. And on the next slide, I do have a lot of the factors that are impacting that test performance. So the instrument, chemical reagents, timing of collection, quality of specimen, the patient biology, and sort of these other real world. So in general, whenever we think about molecular tests versus antigen tests, the antigen tests are a little bit less sensitive, but they are specific. And so whenever we interpret antigen results, it's not only thinking through that positive and negative and then the sensitivity and specificity, we also need to be considering that result in the context of the clinical picture, recent exposures, and the likelihood of an alternate diagnosis. But in general, this slide kind of lists what you would do with a positive result, what this means, and what you do with a negative result. So a positive result from an antigen test, it's highly specific. So it's most likely that the person is infected. However, false positives can occur, and particularly in low prevalence populations. So we just need to kind of, again, keep that in mind whenever we're going through this pandemic response and using it in different communities. Negative results are less sensitive than molecular tests. Again, going back to my previous slide where I kind of showed the differences in the sensitivity and specificity, those numbers can range, and for the Sophia, it's anywhere in the literature from 80% up to kind of almost 96%. So, you know, what number actually is the real world? I think we're going to find out a lot more about that as we use it more. But the Sophia healthcare personnel fact sheet does state that the amount of antigen in a sample may decrease as the duration of illness increases, which that means that specimens collected after day 7 of illness may be more likely to be negative compared to a PCR test. With that being said, the recommendation is that negative results from patients with symptom onset beyond 5 days should be treated as presumptive and confirmed with a molecular assay if necessary for patient management. I do want to also point out that with PCR tests as well, they do have this sort of disclaimer that depending on the patient's clinical history and exposure, even a negative PCR, you might want to think about, should I repeat this PCR test because it's not really matching up what I thought. But I did want to point this out for antigen tests because they do have a lower sensitivity. So the concern for false negatives is potentially a little higher.
Hey, Shayna.
Yeah.
Can I just interrupt 1 second and ask for a clarification? What are low prevalence populations?
Yeah, so low prevalence populations, that's kind of getting back to IDSA says less than 2% prevalence. I know we kind of use that 5% as well. So it's not greatly defined, but it's definitely based on sort of how much virus is circulating in the community. So I would say anywhere less than 5, potentially less than 2% is what is kind of out there, depending on what you use. And CDC also has some definitions as well. So the different organizations are kind of defining it differently. It's just more of a general statement. So it's going to be based on just what's circulating in the community.
Great, thanks.
Yeah. And you can go to the next slide. Yeah. So what we did, you know, kind of again, thinking through this and thinking that we understand and recognize that we've been using molecular tests, but that's not an indefinite resource, and antigen tests aren't an indefinite resource either. But I think that we can go through our nursing home testing recommendations and sort of determine understanding the limitations that you have with antigen tests, but also understanding the turnaround time and the rapid results that you can get from these point of care antigen machines that are going to be distributed. We can come up with some options for those that are using antigen tests to kind of put in and substitute potentially where you would use a molecular test. So this table is published on our COVID long-term care task force website, along with some other information on antigen testing. And so we just summarized each different testing scenario that's in our nursing home testing recommendation guidance that's in the reopening guidance document that we have also on the website. And so if you just go through, you know, we're just taking into consideration that we've already in our nursing home guidance recommended repeat testing due to the known fact that SARS-CoV-2 can transmit sort of silently, specifically in nursing homes, and the nursing home population is a high-risk group. So we do want to be a little bit more conservative. And so the testing recommendations that we took from the CDC always include sort of a repeat round of testing, whereas in the community, that's not something that we would recommend. So thinking through that, we were able to plug in anywhere where we're doing kind of a first round of testing, you could use an antigen instead of a molecular test. But that second round of testing that was already recommended would then be your molecular test, which then would serve two purposes. One, to confirm any negative antigen test, and then also to serve as that repeat test to ensure that transmission has not occurred. So I encourage everyone to kind of look through this document and these recommendations. And you can go to the next slide where I think I summarize sort of everything that we have. So nursing homes are if you're going to use a antigen test, you can follow our updated testing recommendations. We are anticipating some antigen recommendations coming from CDC. So any new information, we expect a lot of everyone's kind of chomping at the bit to get antigen testing recommendations out there. We felt like we could put this out there with what we know, not saying that this is going to be set in stone forever. It's probably going to change based on more information and more data that comes out. So this is what we have right now, but I do just want to caution everyone that there are potential for updates, and potentially soon, if the CDC releases something this week, we will review what they say and adjust accordingly. We are also in the process of making assisted living facility testing recommendations, and so we will be also including some of those, the thought process for when to use an antigen test and maybe when you would want to use a molecular test instead. A negative antigen test should not be the sole basis used to determine if a patient can be taken off of transmission-based precautions. Nursing homes that perform point of care tests are then going to be responsible for reporting results to public health. So the current system is that, the labs report, and then, the facilities might report as well. But whenever you are acting as almost the laboratory, you're going to be the sole reporter. And so you would have to follow up with the local health department on the positive results. We have an online option right now, and our surveillance team is working on an online option specifically for point of care tests to make that reporting slightly easier. And there will be more information from the surveillance team that they are planning on communicating more broadly once that's up and running. Because this is not only affect, long-term care facilities, this also affects outpatient providers, because they can also use these machines and have access to these test cassettes and machines. And then lastly, just as a reminder, suspected and confirmed outbreaks are required to be reported rapidly to the local health department. So in the event that an antigen test is what kind of has confirmed the outbreak, you can submit, up to 5 specimens for molecular testing at the state public health lab, and they'll sort of confirm the outbreak using the molecular tests. So that is, I just wanted to point that out as well. If you are using antigen tests, just as a reminder that we are asking to kind of submit specimens for molecular testing to DCLS for confirming an outbreak. And that is all I had. And I know there's an important conversation about the COVID-wise app from Jeff Stover. So Melissa, I'm fine to stay on the line if I just want to take questions at the end after Jeff goes. Does that work?
Well, if you want, there are only 2 questions for you right now in the chat box. Okay. You want to take them real quick?
Yes, I can.
Okay, so one was, so if asymptomatic, we can accept a positive as such and a negative as such?
If asymptomatic.
I think they mean with using antigen test.
Sorry, so if you are asymptomatic, so PCR test and antigen test are both, whenever they get authorized by the FDA for emergency use, the data that is required for that is not very extensive, and the majority of data is in symptomatic patients. So what we kind of have now is symptomatic data for sort of how to use them. The stretch in using them for asymptomatic patients, kind of those close contacts, is again thinking through, well, if you have a rapid test, would you rather do a rapid test and then maybe confirm that, just to kind of, instead of having a PCR test and then waiting kind of maybe 7 to 10 days for that result. So a negative test in an asymptomatic person is not, I wouldn't say confirmed per se. It's one of those, sensitivity and potentially the test of the antigen test was a little bit too soon, and that's why you got that negative result, and it wasn't enough time for the illness kind of to take course. So we would still be recommending in the long-term care population to repeat that. However, I will say that with close contacts, we do recommend quarantining for 14 days. So even if you had a negative PCR test, there's still that recommendation to quarantine for 14 days because your result is only as good as on the day that you took it. So even a PCR test could be negative and you could kind of be brewing or incubating that infection. And if you repeated that test a couple of days later, it could be positive. So that's why in our guidance, we do recommend if you're an asymptomatic close contact, that first round, you could get an antigen test, but that we do recommend following it up with a molecular test. And we say anywhere from 3 to 7 days.
Okay, so then a related question. I'm sorry, Shana, if you addressed this. I'm trying to keep my head around all this. A related question was, so if all negative results should be confirmed with a PCR, then why use this? Why not just use the PCR to start with?
Yeah, so I think that's the question of, do all negative tests need to be confirmed with a PCR? We know with antigen testing specifically and other tests that have low sensitivity, the more you test, that kind of overcomes that low sensitivity. So there are potentially scenarios where you don't need to do a repeat PCR. I am only talking about antigen in the context of our nursing home testing guidance, where again, we've already had repeat testing built in with PCR. So that's why we're kind of fitting in the antigen test in that first round. If it affects patient management, that's whenever you should be doing that repeat PCR test. And that's why in our guidance, we state you should repeat it with a molecular test. In the outpatient setting or elsewhere, if you want to talk about potentially surveillance testing, doing weekly testing of antigen tests, there's definitely some thoughts out there that you might not have to confirm it. Again, it all comes back to why you're doing the test. How is the patient presenting? Do they have exposures? Do you think they have COVID? And then taking that negative test into consideration. Like I said, there's an anticipation of CDC guidance coming out very shortly that's, I think, going to address some of those concerns. But right now, we are kind of going along with what the FDA EUA says until there is other guidance. And so if you're using it for patient management, you need to be kind of confirming that negative. But like I said, context of a close contact that's asymptomatic, they should already be quarantining. So there have been maybe some discussions of, even if you're negative with an antigen test, would it really affect patient management because we're telling them to quarantine anyway? So again, it's kind of all relating back to why you are testing this person and what the clinical contacts, exposure history, likelihood of an alternate diagnosis, and then going back to whether or not you would then repeat that PCR test. But for the nursing homes, where we have indicated testing, currently it is going to impact patient management, and we've already built in that kind of double testing. So it kind of, if you look at it from that standpoint, you could potentially cut the amount of molecular testing you're doing in half. And the other advantage of antigen testing is that in this scenario, whenever you're using point of care, it is more rapid. So getting a rapid result back within 15 minutes and saying that they're positive is beneficial than waiting for a molecular test to come back. And there are definitely scenarios where in the future we may not recommend a repeat test, but for what we're saying right now for nursing homes, that's the context that I'm presenting the antigen guidance for.
Okay, and then one more question came in. Do we consider a positive result from an antigen test as a confirmed case for reporting, or do we repeat with molecular to consider it a confirmed case for reporting purposes?
So for reporting purposes, you have a antigen test. From a case counting standpoint, we use the CSTE definition. And so right now, CSTE considers a positive antigen a probable case, but we also include that in our daily reporting. So we include probable and confirmed cases. We are not recommending repeat testing of PCR if it's positive. Again, coming back to why are you testing this person? If they're symptomatic and they have COVID symptoms and you test them and they're positive, then I would say that correlates and they are clinically infected and you would treat them as such. And then on the public health side, we will deal with kind of what CSTE says. And like I said, it would be considered a probable case. But we also report out on that, and our surveillance team is aware and is working through that. So we are not recommending to repeat those PCR with positive cases with PCR because it's sort of not necessary for patient management. And that's just more of a case definition that we will just need to work out on our end. But if you had a positive and you didn't think that they were infected, I guess my first question was, why did you do the test to begin with? If for some reason you wanted to repeat it with a PCR, you could, but that is not our recommendation currently with when we are recommending to do a antigen test.
Okay, Shayna. Thank you. I'm amazed by how you keep it all straight, and I am amazed that our members have to do the same. So I so appreciate, as always, Shayna, you being willing to talk to our membership. Thank you. If any more questions come on and you can hang on, I will let you know. Oh, one came in, Shayna. How does that last response impact reporting on CDC?
Yeah, so CDC is in what we're reporting to CDC, or if I could get a little bit more clarification on, I can at least speak to what we report out at VDH. And like I said, we, in our sort of case count online, we include probable and confirmed. But right now, the majority of if you go through our dashboards, you can kind of click PCR testing. So it would be a separate category, and our surveillance team is working through whether or not we're going to be reporting specifically for antigens. And we kind of, again, we follow what CDC and CSE tells us to do as far as reporting out. So we would be following anything that they would say. So right now, the focus has been on PCR testing, but of course, as antigen tests are more popular and become a little bit more widespread, we will also adapt with our reporting on what we report publicly.
So I think the question was clarified in terms of reporting on NHSN.
Oh yeah, so I would, if NHSN doesn't say, does NHSN say PCR only, or just does it say cases? I'd have to look to see what NHSN says, and we would defer to them if they just want PCR, because they might just, if they say confirmed case and they define it, then I would have to check and see exactly what the definition for NHSN says. And that is something that could also potentially be updated in the future. But I don't have the NHSN definitions in front of me, so I'd have to look at that, and I can look that up quickly, Melissa, and get back to you.
Great, thank you. And then another question that came in: we have to test many residents we don't quote unquote suspect due to PPS weekly requirements or upon admission for surveillance purposes. And does this meet the Virginia reopening guidance that had specific requirements for sensitivity and specificity?
Yeah, so like I said, the sensitivity and specificity data is a little bit all over the board, depending on where you look and how you look, and what's being looked at. So yes, we have looked at this in the context of, like I said, what's kind of happening and what we want to accomplish with our testing. So these two antigen tests that are going out, we have the recommendations. And like I said, we're also recommending to repeat with a PCR. So this kind of meets those requirements based on what we're now newly recommending. The first question was, can you repeat the first part of the question?
We have to test many residents we don't quote unquote
Yeah.
suspect due to PPS weekly requirements.
Yeah, so what we recommend right now is doing that baseline point prevalence survey, which for nursing homes has been completed through the GARD and VDH. And then you would repeat that. And as long as there's no more positives in those two, you have to continue. So you kind of stop. There's a trigger to stop. It's not, we're not saying that you need to continually test your entire staff and residents. So if you're continuing to find cases, that's whenever we are asking you to continue to test, because we're concerned that transmission is occurring in the facility and we want to rapidly identify that. So I don't know if you're following the guidance, or maybe you're going a little bit off of the guidance, but what we're kind of saying is that sort of initial point prevalence survey and then the repeat, as long as you have no new positives, you can stop.
And then thank you, Mary, for clarifying. Shayna, she just said NHSN does not say specifically. We'll need follow-up if it's counted as confirmed when antigen test is positive and resident is asymptomatic. So I appreciate you being willing to follow up with us on that, Shayna.
Yeah.
Okay. All right, I think we're ready to, okay, wait, Shayna, one word just came in. Right, but if we have one staff member test positive for social exposure in phase 1, we are required to continue to test. This does not mean transmission occurs, but in phase 1 testing requirements, we have to retest for a single positive staff case, even if no exposure to residents.
Right, and that's due to the concern that you're in phase 1. We want to get you to phase 2 and phase 3, where we sort of relax restrictions. And we know that the concern with long-term care facilities is that as community transmission increases and the staff are kind of getting it in the community, then they're bringing it into the facility and it might go undetected. So it's out of the utmost concern for like sort of patient safety, resident safety, to continue to test until you get 2 weeks of no new positives before you move on to kind of opening up your facility a little bit. That's the process behind those recommendations.
Yeah, okay. All right, thank you, Shayna. If anything else comes in, I'll circle back with you at the end. But I think we'll go ahead and switch gears to the COVID-Wise app. So Jeff Stover, are you on the line from the Department of Health as well?
I am. Can you hear me?
Yes, Jeff, thanks so much for being here, and I'll turn it over to you.
Excellent. Thank you. Appreciate you having us. Shayna, thank you for all that. You're a wealth of information. So we're really happy to be here and chat with you about COVID-Wise. I hope you'll have some questions we can answer as well. The intent of my approximate 5 minutes here is to give you kind of the lowdown on what it is, how it works, why it's important. First and foremost, this is the first app in the United States to be launched using the Apple and Google Exposure Notification Systems framework. That's a mouthful, but if you've been following news about some of this stuff, contact tracing apps, as they're often referred to, Apple and Google formed a collaborative back in February, March-ish. And, that was a unique collaboration where they were working very closely together to put a skeleton together that will use Bluetooth low energy technology that then state public health authorities like VDH could then use to build apps. So Google and Apple did not build this app. They had nothing to do with building the app itself. What they did do is build that Bluetooth framework that we can then use based on the vast majority of smartphones that are in the market. So 90% of all smartphones users that are out there use either a Google or an Android device. So we are hitting a huge part of the population of smartphone users through COVID-Wise itself. So we worked with a vendor called SpringML. We built this and we started in late May on this and got it launched last week via the governor. Do you have internet connectivity via this presentation by any chance?
Oh, Jeff, that's above my pay grade.
Okay, that's all right. If you did, I was going to have you go back a slide and click on the COVID wise. If you click on that blue image, will that take you to, let's see if we get there. It may not. Oh, it did. Okay. So this is a good way to show you if it pulls up. We have a landing page called covidwise.org. That's what you see on that slide there. And it may not get us there. I'm not seeing it yet. But this landing page is where we funnel everyone, right? It is where everyone who is getting marketing materials, etc., would go to. They get everything, information about it. Here it is. Here. So the next few slides that I had, we won't hit those. We'll use the landing page here. This is an example of what the app looks like if you have it downloaded. I hope you all do. And there's a marketing campaign all around this. It's called Add Your Phone to the COVID Fight. So if you're a particular organization, if you have a specific nursing home facility and you would like to support this endeavor, I would encourage you to contact our marketing firm. You'll be able to find them on this landing page. And we can create graphics for you that there's a place at the bottom of this landing page where there's a media kit. And yeah, keep going on down there. Keep on going. So you see supporter toolkit. So there's FAQs, there's fact sheets, and this media kit has all kinds of graphics. We can create graphics for you as well. Those graphics take the same marketing campaign and would have like your logo, for example, and it's blended in with your colors, whatever they may be, that says our phones are in the COVID fight. You can then use those to promote use of this kind of app via your social media channels, via your websites, etc., however you wish. It doesn't cost you anything. It's merely you being a supporter. And if you scroll back up a little, right there. So you see those logos that are scrolling across there. These are all entities that have already, quote unquote, joined the fight. So as people are interested in doing that, they send us their logos, we create graphics for them, and we'll stick it out here for you just so others can see that you're actually a supporter of making this kind of thing work. So if you scroll back up a little bit again, you see those steps. There are 5 steps here. We're starting with the first one. So the question becomes, how does it work, right? So firstly, it's available in the app in the Google Play Store, depending on what kind of device you have. And once you download it, it is using those Bluetooth tokens, right? It's all completely anonymous, guaranteed. We do not collect any location data. We do not collect any personally identifiable information. Nothing in this app ever asks for any of that kind of information at all. So the Bluetooth signals are basically, right, they are radio signals, right? So a lot of people have asked us, well, how does it work? Well, those Bluetooth signals, when you're sitting at lunch with someone and you both have that app installed, they are sharing these Bluetooth signals. That's what you see happening there in step 3, right? You've got 2 phones and your device is creating these random keys about every 10 to 20 minutes. It picks up a different one. That's to help with privacy. And if you're in close proximity with someone else who's an app user, you're sharing those keys with one another. So then if down the road, a day or 2 later, you find out that you were COVID positive and you would like to report that anonymously via COVIDwise, you're going to get a code from the health department because there's case investigators at LeadingAge who are going to be calling every single person who's positive. That typically happens within about 24 hours of receipt of the positive lab result. And when we talk to you, we verify that it's you, and then we give you a 6-digit PIN. And that has to be uploaded into COVIDwise in order to verify that positive result. So that's done so that we can ensure that rogue individuals aren't out there just submitting random fake positive results, right? So then other people are getting these potential exposure notifications, not knowing if they're real or not. So that PIN is required. And once that PIN has been submitted, on a daily basis, your phone is hitting a server where anyone who has submitted Bluetooth keys that said I was positive, I would like to notify people who were in close proximity to me. What gets loaded to that server are just your anonymous keys. So if that person you had lunch with a few days earlier was the person, at that point, that person should be getting some kind of notification. So your friend's phone is looking at that server on a daily basis and looking for Bluetooth keys that have been submitted these are all positives, right? Looking for any there that match any of their own keys in the last 14 days. And if that turns out to be true, and they're within a certain parameter, you had to be within 6 feet of one another for at least 15 minutes over the past 14 days. If those things all pan out, then that other person is going to get that notification that they may have been exposed. And then there are steps that they can take to go through that. And they can contact the health department, they can contact our call center. There's a virtual LeadingAge agent that's in the app itself. And they can follow up with that. So, okay, so let's go back out of that website. And then if we skip before we do that, I'm sorry, my apologies. You see where it said 293,000 downloads, back one more slide. So that was 2 days ago, that's as of the 10th. So as of last night at midnight, we're at just over 305,000 people who have downloaded this app and are now using it. So let's scroll, let's pass the next three because those were all things right there. So why should you use this? First of all, and I said, why should you use it and why should you promote it with people that you know? It's free. It's completely voluntary. You don't have to use this. We hope you will for the betterment of our communities and the health and safety of everyone in Virginia. We hope that you take the initiative to say, I'm going to do my part. It notifies others anonymously if you're positive. Again, no location data, no personally identifiable information. And then you get notifications from others if you're exposed, going through that example that I was talking about. It's very simple to use. We've had very good feedback from it. Obviously, there's always a few pundits who are going to say they don't like it for different reasons. But I would say by and large, probably 95% or greater of the responses we've received have been very positive. We have ratings on the app and Google Play Store of 4.8 and 4.7 out of 5, so that's very good. Again, it uses Bluetooth, not location data, no GPS information, and it will work even if your app is closed. So you do not have to have COVID-wise up and running on your phone. Once you've downloaded it, once you've accepted exposure notifications, then you can close the app. And it's going to work in the background, and it'll send you a push notification if someone, submits something and your phone finds a positive match. And then perhaps, just as important for people who are skeptics, you can delete it whenever you want to. You can delete all the keys on your phone if you want to from the app. Not the best idea if you want to try and get exposure notifications. And Google and Apple have already said from the beginning that once this pandemic is done, and there's no more need for us to be using such an app, it will be deleted from their servers. It's our app's not on their server, but we have to use their framework. So if there's no framework, we can't use it. So I say that just because, there are folks who think that, the government's going to continue using this kind of thing going forward, and that's not true. We're going to use it as long as we need to, as an added tool in our toolbox. And when that's no longer needed, we'll move on from there. So the next slide has the information. There's some examples of the Our Phones During the COVID Fight. And if you had an organization operation that you would like to be sharing these kinds of graphics, this is the kind of stuff we can do for you. So we've got people from all over. There's faith-based organizations, there's hospital organizations, there's pharmacies, there's colleges, there's places like NASCAR and Green Top, right? There's all sorts that have joined the fight. And if you'd like to do that, then I would encourage you to contact us as well. So the next slide. So there's that's an email address that you can use. There's also, which I did not include here, my apologies, there's a COVIDwise at madisonmaine.com. That's all one word, madisonmaine.com. That is our marketing and PR firm. If you send something to COVIDwise at vdh.virginia.gov, we can get it to them, but there is a COVIDwise at madisonmaine.com. And that'll take you right to the marketing folks. If you said, please, get my organization involved in this, then they will get you graphics relatively quickly, as well as lots of other templates that you can use. With that, I'll turn it back over to you guys if there are any questions.
Hey, Jeff, thank you so much. I am one of 305,000. So I've posted the email to Madison, Maine, because folks were already asking for that. One question for you. I know Virginia is the first. Where are the other states on something like this that would be interstate?
Sure. So there's two parts to that question. One is there's about 5 more states that are what I would consider in phase 1 of this. That is the states that have been working on building an app. Someone has to cross the finish line first. That happens to be us, right? The state of Alabama has beta testing going on right now. And so they're not far from launching. And then there's 4 others that are also in the works at the moment. Behind them is a whole nother handful of states that will be, kind of rolling in the second wave. So to get to your second question, or the second part of it, from an interstate perspective, obviously, COVIDwise is only going to work for you if you would like to post your positive result, not posting it, but announce that you were positive anonymously so that other people get some random thing that says, they're potentially exposed. If you want to do that, you have to be a Virginian, because we have to verify your positive result with that PIN number I was talking about. But if you live in DC or, parts of West Virginia, Maryland, North Carolina, especially places where there's a lot of crossover, you could download this app and you could use it. There's nothing stopping you from doing that. And if you happen to be interconnected with Virginians who are using the app, who also uploaded a positive result, you would receive that. You just wouldn't be able to put one in yourself. So that's one part to it. The other part is the upload of those pins. So when I was talking about the person who is positive and they put their 6-digit PIN number in, when you do that, those anonymous Bluetooth keys are what go to a specific server, okay? And that server is what's housing them. That's where the other 300,000 of us who currently have the app are going every day looking for anyone that said they were positive and looking for matched keys, right? That's a Virginia-specific thing at the moment. But what's happening is the Association of Public Health Laboratories is working to stand up a national key server, okay? So all states, or DC, for example, who would like to use a common server, which we will certainly be looking at, I think most states probably will do this, then we could transition what is currently a Virginia server with anonymous keys to our anonymous keys being pushed to this national key server. That way, we all can work collectively without any problems, regardless whether Maryland has their own app and Virginia has its own app. If we're both using the Apple Google framework and we're both using that server, then for all intents and purposes, our processes work the same.
Great. Jeff, thank you so much for being on today and for giving this overview. And I have a feeling we have some members who will definitely join the fight. So thank you so much. I want to transition to Thomas Gates from DMAS. Thomas, are you here to give us a funding update? You probably have to mute yourself, Thomas.
Yeah, I'm falling prey to the double mute. My phone was muted.
Welcome. Thanks for being here.
I only unmuted one of them. Sorry about that.
That's okay.
So just a quick update. I think I've spoken to this group before on this funding, and so I'm not going to give the whole spiel again unless folks would like it. But the basic version is as part of the CARES Act funding that the federal government provided to Virginia, the governor has designated a portion of that to be available for assisted living facilities and nursing facilities to reimburse for eligible COVID-19 costs. They've asked designated DMAS as the state agency that will run this program. One of the important things to note here is that it's not Medicaid. So we're the Medicaid agency. You think of us as Medicaid. In this particular instance, for this particular program, this is not a Medicaid program. It's funded 100% through CARES Act, and we are just implementing it. And so that's important because assisted living facilities are not normally Medicaid providers. There are nursing facilities in Virginia who are not Medicaid providers. They're 100% private pay. And those facilities are still eligible to participate in this program. So you do not have to be a Medicaid provider. We are asking that you enroll with us. You'll enroll in a slightly different way. It's more like a vendor and less like a provider. It's a slightly later lift. We'll still be asking for the file number from your license and some other things like that, just to confirm, cross-check with our list from DSS about who are licensed assisted living facilities and nursing facilities in the state to ensure that you're eligible to receive funds. So we'll be asking for you to enroll with us, confirm that you're a licensed facility here in Virginia, and then you can submit invoices to a vendor that we were able to bring on board, I think, since the last time I spoke to this group. It's a CPA firm called Myers and Stauffer, MSLC. We work with them a lot on with our work with nursing homes and nursing facilities, doing cost settlements and other things. So they're very familiar with our processes and a lot of this community. And they'll basically be vetting the invoices that we get, confirming that the costs are eligible and are supported through documentation, and then less in the case of assisted living facilities, but in the case of nursing facilities where there are some other programs providing funding, we're asking that those funding sources be used first. So we'll be offsetting, if your facility got provider relief funds, which again wouldn't be assisted living facilities, but nursing facilities did get it, or if there is some private pay option that can fund this instead of the CARES Act funding, we would ask for that to be used first. So Myers and Stauffer will be confirming any invoices that they are eligible and well-documented COVID-19 costs, and that there's not some other funding source that you could use first. And then they will be providing that to DMAS, and we will be making payments. The timeline, we're actually hoping to provide this week, which we're now partway through Wednesday. So I'm hoping we will hit this goal, but we're hoping this week to send out letters to, and this will probably be an email from DMAS rather than a physical letter, because we're just trying to move as fast as we can, or maybe both, but certainly an email first. Sending out some guidance that will lay out what I've just said, but in a little bit more detail, lists some of the kind of eligible costs that you can be reimbursed for, lists some of those other revenue sources I was talking about, and also provides both the form that you need to submit to enroll and the invoice document, which is basically a giant spreadsheet where you'll input things like number of residents per day, whether you're having an outbreak or not, things like that. And that's used to both capture the eligible costs and also calculate the kind of maximum payment we'll make for any given facility. So this program is for eligible costs from July, August, September, and October, just those 4 months. And it is there's kind of a maximum facility cap that's calculated differently for nursing facilities and assisted living facilities. For assisted living facilities, it's $4,000 a month, plus if you participate in the auxiliary grant program, you for every grant recipient who's a resident, you get $15 per day per resident. So that kind of increases the maximum that we would reimburse for any given month based on a census of your population during that month. So that's the basic framework. Hopefully this week there will be that clearer guidance, the kind of written formal guidance, communication, the draft invoice document that you'll be submitting back to Myers and Stauffer, and the enrollment form you would submit back to, we're still deciding whether you submit it back to us or to Myers and Stauffer, who will verify it and then send it to us. So that could still change. And we'll do the enrollment and start accepting invoices hopefully by the end of August, and start making payments hopefully by the very beginning of September. So that's the basics. Eligible costs will be ending October 31. So starting in November, we'll no longer reimburse for costs. And then the last invoices will be accepted December 1st, and we'll hope to make final payments by the end of December or the very beginning of January at the latest. So that is the kind of program in a nutshell. Quick overview, again, really hoping by the end of this week to send out that more formal guidance. And we'll be sending that to all of the folks that we have emails for through DSS, which it's like 566 assisted living facilities. So whatever the kind of email that's on record with DSS is who will get it. We'll also be sharing it, obviously, with LeadingAge and with VALA and the other associations to share out. So I think you'll hopefully by the end of this week or early next week start seeing this in your inboxes, communications from the associations. We'll post it probably on the long-term care task force, stuff like that. So we're hoping to get the word out as broadly as we can after there's a little bit more formal guidance to share. So I'll stop there and see if there are any questions.
Excellent. Thomas, thank you for being willing to be back on with us this week and give an update. And we look forward to receiving those emails from you, and we'll make sure that our members know what's happening in our daily update. I don't see any questions in the chat box for any of our presenters right now. So if you have a last minute burning question, just go ahead and enter it in the chat. I'll give it 1 minute just to see if anything comes in. But I want to thank you, Shayna and Jeff and Thomas, for being on. You have such a wealth of information. We appreciate all that you are doing on behalf of older adults and older adult service providers. So thank you for being here today. It looks like,
sorry, I just wanted to follow up with the NHSN question. I do have an answer.
Oh, great, Shayna, thank you.
Okay, so our NHSN expert on our team said from the instructions document, confirmed is defined as a resident with a new positive COVID-19 test result from a viral test, so either nucleic acid or antigen. So that a positive antigen test would be included in the data that they submit to the NHSN CDC module.
Great, thank you for that quick clarification. So Charmaine, I see your question in the chat box, and I'm wondering if you could be a little bit more specific. Are you asking if other communities are attending the virtual conference? And if you want to unmute Charmaine and talk to me, that would be welcome.
Good morning.
Hey.
Hey. Yeah, we were just wondering how, if other communities were attending, and how are they structuring it with their staff that are attending? Like we were thinking, are you getting all the attendees together in a space with a big TV, or kind of, are you making it kind of an offsite retreat? There's so many options.
There are, and you know what, Charmaine, why don't we, we'll send an email out to everybody and ask what their plans are, and we'll get that back out to the membership.
Okay. Thank you.
Thank you, Charmaine. All right, well, with that, I think our call has come to an end. I want to thank our speakers again and thank you, our members, for being here. I hope you have a great rest of the week. And as always, the LeadingAge Virginia team is here to support you in any way we can. Thanks so much.